Great. So I'm just going to share my screen. Great. So hi, everyone. Welcome to today's drop-in session for GI and respiratory. So hopefully you've already attended the sessions for the over-the-counter and genitourinary immunity and malignancy. And today we're going to be covering the GI and respiratory system, which we've done the recorded webinar for already. So hopefully you've had a chance to watch that. We'll talk through it in a bit, but we've got a Slido going. If you've got any questions, or feel free to pop them in the chat, either or, and we'll talk through your questions as well as revisiting some popular slides and things. So just to quickly talk about Pharmacy Foundation. So it was founded in 2018 and was started as a training and development organisation for current and aspiring pharmacy professionals. And now we offer a range of support to undergraduate, foundation and postgraduate pharmacists, and have worked for a variety of credible organisations over the years. So as you can see, we've worked with lots of universities, and we do lots of different courses, not just this revision webinar series. We do kind of postgraduate CPD events as well as clinical simulations. And you can see from this slide, we do GP clinical simulations, and we've been getting back on campus doing some sort of face-to-face learning as well, and hospital simulations in VR and things. So we do a lot, not just these sessions. So just to run you through quickly the team, today's session is led by me, Katie. I'm a respiratory and CF pharmacist working at Sheffield Teaching Hospitals, and I obviously teach for Pharmacy Foundations as well. I do my pre-reg split between GP and hospital, and now I work in hospital, and I've been qualified since March 2020. But prior to that, I did 9 months as a provisionally registered pharmacist because of the pandemic. So I've rotated through lots of different specialities. I've done gastro and now work as a respiratory specialist. So hopefully I'm well placed to cover this with you guys today. Just a reminder to follow us on Instagram, Facebook and Twitter. And we do lots of bite-sized learning posts on Instagram as well as polls on stories and things. So when I was revising for my pre-reg exam, I found it really helpful to have these sorts of like to go on Instagram for this kind of thing, because it's really easy and quick, and it's just there when you're on the bus to work or you're on your lunch break or something. It's there as well, and you can keep up to date with everything we offer on Facebook, Twitter as well. And hopefully you've already joined our WhatsApp support group, but if you haven't, the QR code's on the screen, and there'll be lots of people in that session, just like you, trainee pharmacists. You can answer each other's questions, help each other out when you get to revision and things. So the WhatsApp support group's really helpful. So today's session, as I mentioned, we've got a Slido. The number's on there. If you have any questions, you feel free to pop them in the chat, or you can put them on the Slido. On the Slido, it's good because you can like upvote other people's questions. So if somebody says something and you think, oh yeah, I want to know that too, you can kind of vote, promote it. Or you can put questions in the chat. I'm happy with either. But we'll go through some questions that we've had already today via email and via the Slido. And then we'll come to the Slido again at the end. But as I say, if there's anything as we go along, just pop it in the chat and I'll do my best to answer it. So today's layout is we're going to start. We want you to put this Slido, put your questions on the Slido, as I've said. I'm going to go through some email questions to begin with. And then we're going to go through some of the popular sections of the webinar, the online webinar, the slides, just to talk through them again, the really important points to help you remember. We've got a bonus multiple choice question today, so stick around for that, and we'll be going through the answers for that one as well. And then we'll go back to the Slido at the end to see if there's any questions on there. So to begin with, we've had a question about C. diff. So we didn't touch on this in the GI session, but it is important to know. So Clostridiales difficile is an infection where the normal gut microbiota are suppressed and allows levels of toxin producing strains of C. difficile to flourish. The toxin damages the lining of the colon and causes diarrhea, and the infection can be mild, moderate, severe, or life-threatening. And complications include pseudomembranous colitis, toxic megacolon, colonic perforation, sepsis, and death. So if anybody's doing the pre-reg in hospital, you probably know that C. diff is quite a big deal. And if patients get C. diff, then we have to put them in a side room, kind of treat them for it, we're all washing our hands loads because of C. diff. So it is quite an important infection to be aware of, but obviously patients in the community can get it as well. It's most common in patients who are currently taking or have recently taken antibacterials. So that's because the normal, if you take, amoxicillin, it wipes out the gut flora and allows the C. diff to flourish. So it's usually associated with clindamycin, cephalosporins, fluoroquinolones, and broad-spectrum penicillins. So, for example, with clindamycin, it's really common for patients to then experience C. diff afterwards. And lots of us carry it, but don't know that we carry it, and it sometimes just flares up when somebody has antibiotics. The infection risk increases with the duration of the antibiotics, which makes sense because the longer the course of the antibiotics, the more chance there is to wipe out that natural flora, which is stopping the C. diff from kind of growing. And if you're using lots of different antibacterials at the same time, or you're using multiple courses, again, that increases the risk as well. Other risk factors for C. diff include use of acid suppressing drugs such as PPIs. Patients are over 65. If they're in hospital for a long time, they're obviously more likely to catch it because they might be exposed to patients with C. diff. And if they've got underlying comorbidities, and again, being exposed to people with C. diff. So that's why it's really important as healthcare professionals in hospital that we're washing our hands before and after seeing every patient to make sure that if we carry it, we're not spreading it, or if a previous patient's got it, we're not spreading it to someone else. And if you've had C. diff once, you're more likely to get it again. So in terms of choice of antibacterial therapy, we would recommend usually, so the NICE guidance recommends vancomycin orally first line. And you can't use it IV because it doesn't penetrate the gut. And you use it orally because if you give it orally, it doesn't enter the bloodstream, vancomycin. And the second line is fidaxomicin. So I know at my trust, we sometimes use metronidazole as well, and fidaxomicin is incredibly expensive. So we usually use vancomycin. If it's not working after first and second line treatment, we would seek specialist advice. And a specialist may offer oral vancomycin with IV metronidazole, depending on kind of how patients get on. You can give it down PEG tubes. You can give the vancomycin IV down a PEG or an NG tube, which is what we do. And some trusts use IV vancomycin orally first line, but we use the capsules at Sheffield. So hopefully that's covered a little bit about C. diff. If you want to know more, have a look in NICE and BNF, but that's just sort of to touch on it because we didn't really talk about it during the session. The next question was about which guidelines do we need to know for asthma? Is it the NICE guidelines or the BTS sign guidelines? So I think this is the question that comes up a lot. And to talk through this, I'm just going to flick back to the slide that we had in the webinar about asthma, because we can talk through the treatment options and we can discuss the differences. So we say know the NICE guidelines. There's not that many differences. So I think the way I approached this when I was doing the exam was I learned the NICE guidelines and then I knew the differences with the BTS one. So I knew the NICE one, and then I could just sort of slot in the BTS as it went. So the NICE guidance is national, which is probably why we do it. But as I mentioned in the webinar, they're looking at combining the two, and hopefully that will happen quite soon, because I do agree it is confusing having two different conflicting advice. So the NICE guidance are here on the left, and they recommend that we start off with a SABA. And then we give a patient SABA and ICS if that's not working. So as I mentioned in the webinar, it's important that we're checking with patients at every point that there's no alternative diagnoses, there's no lack of adherence, they're using their inhalers properly, and they know how to use them. So, you all hear the classic example of people spraying the SABA on their neck, things like that. It's important that we check that they know how to use it and that they're on appropriate formulation. So for some patients, they just don't get on with PMDIs. It's obviously can be quite challenging for patients to squeeze the canister and inhale at the same time. I'm coughing in as we speak. So for some people, they might get on better with a dry powder where they just have to flick it open and then breathe in deeply and fast. Whereas with the SABA, they have to puff and breathe in slowly at the same time. For some people, if they've got like rheumatoid arthritis, that motion of the pushing is really difficult. So then we can recommend breath actuated inhalers. There's lots and lots of different options. You can use spacers. So it's important that patients are actually using their current therapy correctly before we step them up. Otherwise, they end up on sort of step 5 when actually they just didn't use the inhalers properly to begin with. So we need to check that they're not smoking. So I always bang on about in these respiratory sessions is it's really important that we encourage patients to quit smoking, especially if they've got asthma or COPD. And as we know about COPD, it's one of the biggest causes of COPD is smoking, but we'll come to that. So we're talking about asthma at the moment. So we should check that there's no occupational exposures and no psychosocial factors, or is it a seasonal or environmental issue? So I think I touched on this in the webinar that patients may struggle with seasonal asthma. So for example, during the cold weather, they might notice that they need the SABA a lot more. So we might just need to give them a steroid through the winter, or vice versa if they've got hay fever. So it's something to think about, because some patients don't need to be on it all the time if it's seasonal. After we start or adjust medications, we should review this response to treatment in 4 to 8 weeks, and patients should always have an asthma action plan written down. So NICE say that for adults with asthma who have infrequent short-lived wheeze and normal lung function, we should consider treatment with a SABA reliever therapy alone. So this is the first difference with the BTS guidance, is BTS is saying go straight in with a SABA and an ICS, which was quite a recent update. And this has sort of been well regarded in the kind of national guidance, is that we should be giving both. So BTS say give the ICS immediately, never give a SABA alone. And that's because in a lot of the patients who have passed away from having an asthma attack, it's patients who were on a SABA alone. So they're recommending to go straight to the ICS. But NICE say start with the SABA, and you can consider an ICS at step 1, depending on the patient. Then we move to a SABA plus ICS. Kind of that's if they're not controlled on the SABA, as per NICE. And then they're saying step up to add in a leukotriene receptor antagonist. So that would be montelukast. Montelukast is kind of, patients should try it, and if it's not working, then they shouldn't continue. Like, there's no point being on something that's not working. So for this instance, we would say if they try the leukotriene receptor antagonist and it's not working, and then we get into step 4, we should consider whether they should continue it or not, and take into account the degree of response to the LTRA. This is another difference with the BTS guidance. So the BTS guidance at step 3 is saying add in a LABA instead. So it's basically got step 3 and 4 the other way around. So that's the main difference between the two. And that's not that difficult to remember. So I would say between step 3 and 4, you just remember that they're switched in BTS compared to NICE. Then we're moving on to kind of all 4 together. So we've got SABA, ICS, LTRA, and LABA, and that's if they've had a good response to the LTRA. Then we can move on to a MART regime, which is giving a single inhaler, which contains both the ICS and a fast-acting LABA, which is used for both daily maintenance and the use of reliever therapy. Another small difference between NICE and BTS here is that NICE is recommending a MART regime for people with asthma who are on a low-dose ICS, whereas BTS say they should use a medium-dose ICS. So that's another slight difference. But in day-to-day practice, decisions on inhaler regimens depend upon consultation between the physician and the patient based on technique, compliance, and convenience for the patient. And the evidence reviewed in both sets of guidelines would suggest that a MART regime is a viable option, and discuss with the patient whether it should be low or medium dose. But NICE is saying start with a low dose and you can go up to a medium dose, whereas BTS say start on a medium dose. So that's a slight difference again. Then we're moving on to sort of section 5, which is where we're saying we start with a high dose MART. And at this point, we're starting to think there's something a bit more serious going on, and we might need to move to specialist therapy. So we've got that we should be using potentially theophylline. Theophylline obviously is a xanthine. We prescribe it by brand, and in overdose, it can cause vomiting, agitation, restlessness, dilated pupils, sinus tachycardia, and hyperglycemia. So this is another high-risk drug that you need to be aware of. And in a plasma theophylline concentration of 10 to 20 milligrams per litre is required for satisfactory bronchodilation, although some people find that it gives them enough at 5 milligrams per litre. So it depends on the patient. But adverse effects can occur in the therapeutic range as well as higher. We should measure the plasma theophylline concentration 5 days after starting oral treatment and at least 3 days after any dose adjustment. And we take the blood sample 4 to 6 hours after an oral dose of a modified release preparation, but sampling times may vary and consult local guidelines. So I know at my trust we do it pre-dose, not 4 to 6 hours after, but that is what it says in the BNF, is 4 to 6 hours after. Then we're moving on to using an antimuscarinic. So you've got to be careful when recommending antimuscarinics, because they're commonplace in COPD, but then a lot of them aren't licensed for use in asthma. So for example, a Braltus inhaler is not licensed for use in asthma, but the tiotropium Respimat is. So it's just something to be aware of when if you're asked to make a recommendation. And an app that I can recommend is the Right Breathe app. I didn't talk about this in the webinar, but it's brilliant because you can literally just put in like asthma, adult license, the type of inhaler that you want, the drugs that you want, and then it gives you all the options. So it's really helpful in practice when somebody says to you, oh, can I have a Seretide Evohaler instead of an Accuhaler? Well, no, because the Accuhaler is the one that's licensed in COPD. Things like that is really helpful. And then step 5.4, we're looking at using oral steroids. So that's not something that we really like to do, is keep people on steroids all the time. And that's definitely a point where we should be looking at specialisms. The BTS guidance goes into a bit more depth with kind of the alternative therapies, such as, I say alternative, I don't mean like herbal medicines, but I mean further down the line what we can use. So the NICE guidance doesn't discuss kind of anti-IgE monoclonal antibodies, anti-IL-5 antibodies, or bronchial thermoplasty, which are all approved by NICE and we do use in severe asthma services across the UK. So I know at my trust, we have a weekly MDT where we're discussing starting patients on mepolizumab, omalizumab, benralizumab, and dupilumab. So they're the ones that kind of we might be using for asthma, and that has to be a conversation where consultants, at least 2 consultants are involved, as well as the MDT, and they look at various things to do with the asthma to make that decision. But NICE doesn't touch on that, whereas BTS does. So hopefully that it's clarified the differences between the two, and obviously running through how we dose them again. So in referral criteria is saying if the patient's less than 5 years old, we can get up to 0.3. So that's SABA, ICS, and LTRA before we refer. And in children 5 to 16, we're going to get to 5.2 and then consider referral. But practically, often it is done earlier, especially if it's kind of we're whipping through them and it's really not improving, then it can be done earlier. And the different steroid doses. So BTS describe it as very low, low, and medium, whereas NICE describe it as kind of pediatric low, moderate, and high. So the slightly different terminology, but there's a nice table in the BTS guidance, I think, that sort of discusses what each of those doses mean. So that's one to have a look at as well. Hopefully that makes sense. Has anyone got any questions about asthma management in the chat? Hopefully not. Brilliant. Hopefully I've not spoken too fast as well. That's kind of asthma covered then. So we're going to go through some of the slides we covered in the webinar and just talk through them again. Kind of the popular big hitter slides that you really need to know. I mean, you need to know most of it, but we've got IBD versus IBS. So obviously this session is covering GI and respiratory, and as I'm a respiratory pharmacist, I can waffle on and on about respiratory, but it's important we don't forget gastro as well. So the differences between the two is that IBD is inflammatory bowel disease and IBS is irritable bowel syndrome. And they're kind of the differences is IBD is an autoimmune disease and there are no discernible triggers. So IBD just sort of occurs and there's nothing really that says that's what's kicked that off, or you don't eat something and then you get a response. Whereas IBS tends to be involved with the brain and triggers do exist. So a patient might notice that, for example, if they eat onions, then their IBS flares up. So IBD, inflammatory bowel disease, is inflammatory in nature, as the name suggests, which we can detect by colonoscopy and other diagnostic tests such as fecal calprotectin. And there's two main types of IBD. We've got Crohn's and ulcerative colitis, and the symptoms of IBD are bloody diarrhea, abdominal pain, cramps, tenesmus, which is the urge to pass stool even when the bowels are empty. And patients often suffer with weight loss as well. So that's kind of the IBD side of it, whereas IBS, you're not getting any results on a colonoscopy or any other diagnostic test really. So often patients with IBS are diagnosed through ruling out of IBD. So if a patient presents with kind of abdominal pain, because the symptoms are incredibly similar, apart from the blood in the stool, which patients with IBD might experience if they're having a severe flare, that would be unusual or unheard of in IBS. So if a patient presents with abdominal pain, cramping, tenesmus, it could be either. So they'll run tests to rule out IBD, and then if they're sort of left with nothing, then we're at IBS. So IBD, we can use fecal calprotectin to test for that. We can use the colonoscopy, and if you aren't too squeamish, you can have a look at the colonoscopy images to see what an inflamed bowel looks like compared to a kind of normal bowel. And so IBD is a group of diseases, so it includes Crohn's and ulcerative colitis. And as I mentioned, you often get the bleeding. So patients may suffer with anemia as well. And the bleeding is, depending on which bit of the bowel is inflamed, depends on the type of blood. So we've covered that as well in the webinar, is the different types of blood and what they mean. And we've got IBS as a group of symptoms which can cause stomach pain, discomfort, diarrhea, and or constipation. So that bit is the same as IBD, but they're very different mechanism of action. So hopefully that makes sense, the differences between the two. IBD versus IBS, obviously the treatment is incredibly different because of the kind of mode of action of the diseases. So we'll talk about IBD quickly and the treatments. So in terms of inflammatory bowel disease treatment, we've got acute Crohn's disease. So patients will either have acute or kind of in remission. And acutely, patients are going to present with often increasing amount of stool, fever, depends whether they've got systemic symptoms as to what we do. And that's often might be the first presentation if a patient's presenting with, acute blood in the stool, going to the toilet 10 times a day. Can be quite distressing for a patient, and we want to kind of double check that everything's okay. And if it's a diagnosis of IBD, then often they come into hospital, especially if they're losing fluid and they're systemically unwell. So usually first line, we can use a monotherapy. So a corticosteroid for single inflammatory exacerbations in the last 12 months, we usually use prednisolone. At my trust, we use prednisolone 40 milligrams. But if they're admitted and they need IV, we would give hydrocortisone IV. If they've had 2 or more exacerbations in the last 12 months, we can add azathioprine or mercaptopurine to a conventional corticosteroid or budesonide. So, or we can use methotrexate and a steroid. So that's kind of acutely how we manage it. And what we want to do is induce and maintain remission. So some people will just have acute course of steroids and then continue with their usual maintenance therapy. It sort of depends how it's going, because if they're kind of not had a remission, not had a flare for ages, then we might just continue their usual therapy, or we can step up their therapy. So first line, the maintenance of Crohn's would be azathioprine, mercaptopurine, or methotrexate. And if you remember that, we need to test the TPMT levels for patients with azathioprine and mercaptopurine. So if a patient has reduced TPMT, the thiopurine drugs are not well metabolized. Therefore, there is an increased risk of myelosuppression. And we cover this, you should have covered this you will cover this in the immunity and malignancy session as well. If they've got ulcerative colitis, it's slightly different. So if you think about Crohn's, it can occur any part of the GI tract. So obviously it can occur in your stomach, it can occur like in the mouth, in the esophageal tract, all the way to the rectum. Whereas ulcerative colitis occurs in the colon and in the rectum alone. So we can use like topical treatments more effectively in colitis, and if the Crohn's is affecting the colon. So we can use, if it's proctitis or proctosigmoiditis, which is the rectum and the colon, we can use a topical aminosalicylate alone, such as a suppository or an enema. So obviously if it's in the rectum, we don't need to give an enema because we don't need to coat the whole of that colon. We can just give a suppository. Or we can add an oral aminosalicylate, which actually is released in the large intestine. Alternatively, we can give a topical or an oral steroid, such as prednisolone. Again, we can look at kind of giving budesonide enemas, things like that as well, depending on which bit is affected. If it's left-sided and extensive, we can give a high-dose oral aminosalicylate, and we can consider adding a topical aminosalicylate or oral beclomethasone. Again, we should be discussing smoking cessation with patients, as this can impact inflammatory bowel disease. I love talking about smoking cessation. And you shouldn't offer a conventional glucocorticosteroid or budesonide to maintain the remission. So it's for acute treatment alone. We don't use it to maintain. If it's left-sided, we can give sulfasalazine, and it's converted into mesalazine and sulfapyridine in the colon. Another option is surgery. So we've not really talked about surgery, but it is a treatment option. So I think patients think of it as treatment failure, but especially for colitis, it can resolve the symptoms, because obviously they've got a stoma, which isn't easy. And I'm not saying it's for everyone, but if a patient's in pain and constantly having flares, they might choose that that's better for them. So it's something that we do sometimes give patients kind of remove the whole colon, and sometimes remove the rectum, sometimes they leave it behind. It depends on the patient. But in Crohn's, we're less likely to do that because it can affect any bit. If you remove the inflamed bit and sew the two bits back together, then you're increasing the risk of adhesions and scarring, and it's not always the best option. Whereas with colitis, if you remove the whole colon, you remove the disease. So surgery is an option as well. As I mentioned, in acute severe ulcerative colitis, we would give IV corticosteroids or plus minus cyclosporin. At my trust, we don't really use cyclosporin that much, but it can be used as well. Just depends kind of locally what guidance. So hopefully that's makes sense. That's IBD sort of covered. Has anyone got any questions about any of that? I've lost my chat box, so I'm hoping that that's a no. Great, we will move on. So asthma, back to respiratory. So we're going to talk a bit about this slide, talk through this slide again, because I think it's really important that you kind of know a bit more about asthma and how it works. So it's a reversible obstructive disease of the airways that's commonly diagnosed in childhood. And the key symptoms are wheezing, chest tightening, shortness of breath, and cough. And symptoms tend to have a diurnal variation, which we can spot using peak flow readings, which we'll talk about in a bit. It's got a genetic link. So if patients have family members of asthma, they're more likely to have it, and if also linked to other conditions like eczema. Symptoms can be induced by exercise, allergens, cold air, infections, pollutants, and cigarette smoke. So again, we want to be encouraging patients to quit smoking, and if a family member has asthma, encouraging the family of the patient to quit smoking as well. In terms of diagnosis, so there's different tests we can do. We've got the FeNO test, spirometry, which is the gold standard, and a peak flow test. So the FeNO test is where a patient breathes into the machine and we measure a level of nitrous oxide, which is a sign of inflammation. We should offer the FeNO test to adults if a diagnosis of asthma is being considered, and if the level is more than 40 parts per billion, or it's a positive test. And we can consider doing a FeNO test in children if there's diagnostic uncertainty after initial assessment and they've got either normal spirometry or obstructive spirometry with a negative bronchodilator reversibility test. The minimum age for doing all this is really the age of 5, and that's because it's quite difficult to explain to a child under that how to do these tests, how to blow in a certain way. So for children under 5 with suspected asthma, we would treat the symptoms based on observation and clinical judgment, and review the child on a regular basis. And then when they get to 5, hopefully send them for these tests. So as I mentioned, the gold standard is spirometry, which is where we're looking at the forced expiratory volume in 1 second over the forced vital capacity. So we're looking at the ratio between the two. So the forced expiratory volume in 1 second is how much a patient can blow out in 1 second. So a hard, fast blow, whereas the forced vital capacity is trying to measure the capacity of the lungs overall. So how much can a patient blow out? Kind of, it doesn't matter how long it takes them, it's just how much they can blow out. And we want the amount they can blow out in a second versus the overall amount to be more than 70%. And if it's less than 70%, then this is a positive test for obstructive airway disease. And that goes on to obstructive spirometry is what that's called. And if it's positive, we can do a bronchodilator reversibility test. So that's where we do the test in a patient's FEV1 over FVC ratio comes back to less than 70. Then we give them a SABA, such as salbutamol, and we see how much they can blow out if it resolves it, basically. And if it resolves it, then that's saying to us that it is obstructive and it is going to respond to treatment. We've already talked through the treatment, so I'm not going to talk through it again. If you go back to the previous slides where we've talked through the difference between the NICE and the BTS. And we've got peak flow as well as another way of diagnosing. So as I talked about with that diurnal variability, patients will have a target peak flow and they should know what that target is as part of their asthma action plan. And if they think they're experiencing a acute asthma attack, if you look on the kind of grading of the asthma attacks, it also talks about it in terms of the percent of peak flow. So if they're hitting their peak flow target, then that probably means it's less likely to be an asthma attack, whereas you can use it to grade it in terms of mild, moderate, severe, or life-threatening. So the peak flow is literally just a tube and a patient blows and the arrow moves to a certain point. And if they know what the target is, they'll be able to read where it is. And they can do it in the morning, they can do it at night, can do it after treatment to measure how they're kind of getting on. The treatment aims for asthma. So we don't want any daytime symptoms or no nighttime waking due to asthma. We don't want patients to have to use rescue medication or you have an acute asthma attack. And there should have been no limitations on activity, including exercise. So I think historically patients thought that if they just had to use their SABA before they were exercising, then that meant that their asthma was well controlled. So if they were fine the rest of the time and they used it before they exercised, they thought that that meant their asthma was well controlled, but that's not the case. We should be hoping for no use of SABA or no use of anything other than kind of in an acute asthma attack. And if they're having an acute asthma attack, then their asthma is not well controlled. They should have a normal lung function. So they should have a FEV1 or peak expiratory flow greater than 80% predicted or best. And they should hopefully have minimal side effects from their medication. So that's asthma treatment. Hopefully that all makes sense, and that's sort of the diagnosis, the things we can do to help patients, and we've covered the treatment already, so I've not gone into that in too much depth. So moving on to COPD, another respiratory disease. So this one is the NICE CKS guidance adapted into a NICE poster, and the biggest intervention we can make is stopping smoking. If you remember anything from this session, it's tell patients to stop smoking, or encourage patients to stop smoking, I should say. So we start off with a SABA or a SAMA, and this one, we're not necessarily going to add in the other treatment straight away. It depends on how the patient's going. And if you think about the difference between the two diseases, is asthma, we want the patient to live a normal kind of, that we want them to live like they've not got asthma. Whereas COPD is a progressive disease. Patients can't get rid of it. We can't necessarily fully manage their symptoms. They're not going to kind of get better, which is quite difficult for patients to kind of get to grips with. So initially we start them on a SABA or a SAMA. As I mentioned on the recording, we often just use a SABA rather than a SAMA, because if they start on a LAMA, then we have to stop the SAMA. So you can't use a SAMA and a LAMA together because of the cardiac side effects. So we usually just kick people off with SABA straight away. And again, same thing of if we're using a SABA, we can use various different inhaler types. We can use the PMDI, the dry powder, using a spacer, anything like that. And we've got, if they've got no asthmatic features, and we define, so asthmatic features in COPD help us kind of go down what treatment route we're going to do. Because there's no point giving somebody a steroid unless we think that they're going to benefit from it. So if they have a previous secure diagnosis of asthma or of atopy, so if they've had asthma when they were younger, then that if they've got a higher than usual blood eosinophil count, if they've got a substantial variation in FEV1 over time, or a substantial diurnal variation in peak expiratory flow of at least 20%, then that counts as an asthmatic feature. And if they do, we start them on a LABA plus an ICS. So the risks of ICS, we can kind of increases the risk of pneumonia, basically, in patients with COPD. particularly in patients with older age, lower BMI, severe airflow limitations, low blood eosinophil counts, and it's particularly with fluticasone. So it's not without risks to start an ICS in a patient with COPD. So definitely something to think about when you're sort of discussing treatment options with patients. If they don't have asthmatic features, we can just kick them off with a LABA/LAMA inhaler. And where basically, if they're hospitalized or they continue to have day-to-day treatments, or they have greater than 2 moderate exacerbations, which require a systemic steroid or antibacterial, we add the drug class that's missing. So if they're on a LABA/LAMA, we can add an ICS, or if they're on a LABA/ICS, we can add a LAMA. I don't know, at my trust, the other things, the COPD nurses are absolutely brilliant, and they will come and see every patient that is referred who has come in with a COPD exacerbation, and they'll optimize therapy. So they do a lot of what we could do. So like they check inhaler technique, they review the therapy, they see whether they need to be stepped up. And with the new triple inhalers, they sort of discuss which one's best for the patient. So Trimbo and Trelegy. Trimbo is PMDI, and it's a LABA/LAMA ICS, and so is Trelegy, but Trelegy is a dry powder, and that's 1 puff once a day, whereas the Trimbo is 2 puffs twice a day. So sometimes patients get on really well with their PMDI. So if they're on a blue inhaler, a blue salbutamol inhaler, then they might say, oh yeah, I want that more, rather than trying to switch of devices. Or if they're on a LABA/LAMA before that, they might say, oh, actually, I prefer the DPI, let's carry on with Trelegy. So that's sort of how they make the decision. But our COPD nurses are brilliant. And if you've done the LABA ICS and LAMA combination, we're sort of needing to refer. So the other treatments we can consider are theophylline, as we mentioned with asthma. We can use carbamazepine, which is a mucolytic and helps patients bring up the sputum. So that can help ease their breathing because there's less sort of sputum clogging up their lungs. And we can only continue that if there's an improvement. So they should be reviewed. And if they're not improving, there's no point continuing it. We can also give patients prophylactic antibiotics, but again, that's a consultant decision. So such as azithromycin 3 times a week is what we usually use, or they can be on roflumilast. The other things we need to consider for treatment, obviously smoking cessation. We need to offer pneumococcal and influenza vaccines, offer pulmonary rehab if it's indicated, and we should co-develop a personalised self-management plan with patients and optimise treatments for comorbidities as well. And as they get further down the line, they might end up on long-term oxygen therapy, aiming for 88 to 92. As we talked about during the webinar, we talked about why we have lower target saturations for COPD. So that's sort of the end of our review of these slides. So we're going to do a multiple choice question now. So Mr. P is 62 years old and has recently been diagnosed with a flare of his ulcerative colitis, and it's his first flare in 3 years. He also has COPD and he smokes 15 to 20 cigarettes a day. He's currently on salbutamol, 100 micrograms PMDI, 1 to 2 puffs, Onoro Ellipta, which is a LABA/LAMA inhaler, inhale 1 puff once a day. He's on prednisolone 40 milligrams per day for 1 week and is reducing by 5 milligrams every week until 0. And Salifalc enema 2 grams at night as his maintenance therapy for his ulcerative colitis. Which of these is the least appropriate counselling point? So I'm going to put a poll up. So the options are, should we tell him to carry his, so it's the least appropriate, remember. So carry your steroid card with you, take your prednisolone in divided doses through the day. Should you discuss smoking cessation with the patient? If they're unwell, should he double his daily dose of steroids? And should we advise the patient about potential side effects of adrenal suppression, immunosuppression, and psychiatric reactions? So if everyone wants to vote in the poll, which of these is the least appropriate counselling point? So we've kind of combined this patient. So I don't know if at my trust anyway, the gastro consultants are really keen on weaning steroids, even if they've not had repeated courses. We would recommend, they often do a weaning regimen anyway, and they'll start people on bone protection and calcium and vitamin D prophylaxis. So my trust are really keen on weaning steroids. There's just a few people that haven't had a go at this question if you guys want to have a try. It's all anonymous, so we can't see who's clicked what. So have a go. Which of these is the least appropriate counselling point? Oh, bro, everyone's answered. So most of you have gone for the correct answer, which is B, take the prednisolone in divided doses throughout the day. Brilliant, well done. So the reason for that is we should counsel patients about using a steroid card. So there was an MPSA alert in August 2020 about steroid emergency cards, and they should be issued to patients with adrenal insufficiency and steroid dependence for where if they miss doses, they might have surgery, or if they're ill, they might be at increased risk of adrenal crisis. And we should be giving it to those with primary adrenal insufficiency, those with adrenal insufficiency due to hypopituitarism requiring corticosteroid replacement, and those taking corticosteroids at doses equivalent to or exceeding prednisolone 5 milligrams daily for 4 weeks or longer. So that's why he meets that criteria, because he's going to be on 40 milligrams to start with, and then he's going to be reducing it by 5 milligrams every week until 0. So it's more than 4 weeks, of course. And if patients have taken multiple courses of steroids, so if they are taking corticosteroids at doses equivalent to or exceeding pred 40 milligrams daily for longer than a week, or they've had repeated short oral courses, we should be giving them a steroid card as well. And if they've taken a course of oral steroids, they should carry, if they've had long-term therapy and it's stopped, they should carry a steroid card for a year afterwards as well. And the card includes a management summary for the emergency treatment of adrenal crisis and can be issued by any healthcare professional managing these patients. So if a person is receiving long-term treatment of greater than 3 weeks, we should issue a steroid card. As I said, so it tells patients about what the signs and symptoms of adrenal crisis are. And at my trust, if they're going to be on it long term, we would issue an adrenal insufficiency kit, which is a dose of hydrocortisone, which the patient administers to themselves IM. The reason we don't take prednisolone in divided doses through the day is because if patients take it in an evening, then that puts them at increased risk of adrenal suppression. So we'll talk about this more during the endocrine session, but we take advantage of that when we do the dexamethasone suppression test for Cushing's disease. But normally we want patients to take it in the morning because the cortisol levels, it mimics naturally what the body does. We should always discuss smoking cessation. I'm really glad none of you picked that. Smoking cessation is a big intervention for both COPD and IBD. So it's definitely something we should be discussing with them. As part of that steroid treatment, we should recommend that they double the daily dose after discussion with the doctor about of the steroids, because they might, as the body's under stress, we would usually release more cortisol, but obviously if they're being suppressed through taking steroids, then the patient might not know to do that. And the body won't know to release double the dose, and you require more when you're stressed. So that's why we should say, if they're unwell, they should consider doubling the daily dose, but I would usually recommend they discuss that with the doctor before they do it. And we should advise the patient about potential side effects of adrenal suppression, immunosuppression, and psychiatric reactions. So that's sort of a multiple choice question talking about counselling points with a bit of information about IBD and COPD as well. So, Atif, has anybody said anything on the Slido?
Right, so let's just have a quick look for you then, Katie. So I'm just going to refresh. And if there's any further questions, guys, and also hope you have enjoyed the session, and thank you ever so much for delivering it, Katie. If you do guys have any questions, to make sure that you pop them into the chat. I mean, there could be questions about GI and respiratory, or alternatively, if there are any questions that you have, about exam prep or getting into the swing of things, then feel free to use this time wisely. I've logged into the Slido, Katie, and there aren't any further questions on there. So I guess we can just open it up to those on the call. And if there aren't any further questions, then maybe we get to finish it a little bit early.
Yeah, I mean, I'm happy to talk about exam prep because it's not that long since I did mine. I did it in March 2020. Oh, it is nearly 3 years. That's flown. So I think for exam prep, the way that I found really helpful was obviously using these sessions as a starting point. And these are really good for just like refreshing your memory from what you've learned at uni, the basics that you might not cover every day at work. Like don't always have time to look through the guidelines for everything. So I started with these. And then I made flashcards for the various different treatment summaries in the BNF. So using these notes and using my own notes from uni and from the BNF itself, using the treatment summaries to kind of cover the various different conditions, and then using that as like a spring point to cover the drugs. So rather than learning about calcium channel blockers in isolation, I would learn about them in the context of hypertension. Or rather than learning about SGLT2 inhibitors on their own, I would learn about them in the context of diabetes. And I think that helps. You need to be able to rationalize and understand how the conditions work to help you answer the questions. So that was sort of how I covered the clinical, and I used my flashcards like when I was at work on my lunch break. Like there was quite a big gang of us as pre-regs, so I would speak to everyone at work and talk to them about it at lunch, or when I was on the journey to work, if I got the tram, I would just sit and look through like flashcards on my phone. And obviously doing mock exams is really helpful, and like various, setting questions for each other. With like my colleagues at work, we had kind of a question bank that we would do, like, if you write some questions, and if you write the questions, you really understand why the answers are incorrect or correct, which can help you when you're revising as well. So you guys are about 5 months out, aren't you? Or 6 months out. So I think you should be thinking about it now, definitely. Obviously, you're attending these webinars, which is absolutely brilliant, and you're kind of getting going already. Pace yourself. Don't kind of go hard, and because you're not going to survive for 6 months of doing like constant revision. Obviously, make sure you look after yourselves, and pace yourself. And for the calcs, you just have to practice. Like it's dull, in terms of like you just have to sit and do calculations, but that's kind of what you have to do, I think. So you can get obviously there's various different revision, the types of questions that are going to come up, because obviously they tell you that. So you just need to practice them. You need to just get hold of you can get hold of a book and practice through mock exams and things. So I'm sorry, that's really not helpful in terms of calcs, but you just have to practice and practice with the calculator that you're going to take in, because it's all well and good having a scientific calculator when you're practicing, but obviously you can't use that in a real exam. Or I don't know, I couldn't anyway. I had to take in like a bog standard boring one. So yeah, that's how I kind of practiced with my calcs and my clinical. So someone said, what level of detail do you reckon would suffice in terms of exam prep? I'm afraid I may miss out on important details or end up wasting time on unnecessary things. Well, it's quite difficult to know what's going to be unnecessary and necessary, because obviously they can't test everything. So what they test one year is going to obviously be different to what they test the year after, and what might be deemed necessary one year is not what's going to be necessary the year after, if that makes sense. So they're not going to ask the same questions 2 years in a row. So let's say you revise steroid card, the steroid counselling points. Well, that might come up or it might not. You've got no way of knowing that. So I think you've got plenty of time. I wouldn't worry about missing out things, because if you're going through the BNF and you're going through these sessions, you're going to cover a lot of the content. And kind of you've also got to think about, what does a day one pharmacist need to know? So it's not what does a specialist respiratory pharmacist need to know, it's what does a day one pharmacist need to know. And that's what they're looking at when they're looking at the questions, is how many people who are day one pharmacists should get this right. So it's not, you don't need to know necessarily kind of in-depth knowledge about oxygen therapy and how it started at home, or like oxygen settings on a non-rebreathe mask. You don't need to know that, but you need to understand the basics of why we give oxygen therapy. And I'm thinking of oxygen therapy as an example, but you need to know, I would expect a day one pharmacist to know the COPD guidelines, the asthma guidelines, that I'd like the basic nice guidelines of what you're going to do, because that's kind of that's what you've trained for. And I think you need to know, the obvious contraindications to each drug, the obvious side effects. You might not know necessarily, obviously there's hundreds of side effects on some drugs, isn't there? But does that kind of answer the question? I don't know if I've waffled on a bit there, but I think you need to know what's a day one pharmacist need to know. And obviously for you, that might be different to what somebody else thinks, but you've also got to imagine that they're testing community, hospital, GP, all these different types of trainee pharmacists. So as a hospital pharmacist, my OTC knowledge was abysmal, and I really had to work at OTC because I just didn't see it. I just didn't see it. And like using kind of my colleagues who I knew from uni who worked in community, and like talking to them. And because if you're a community trainee, you're not going to see IV hydrocortisone, you're not going to see all these different MABs. And so when you're doing your revision, think what do I need to know on day one, and be able to recognize an important and vital information. Exactly. So you know that you need to know your COPD, you know to know asthma from this session, like IBD, but you would be expected to know if somebody presented in hospital, let's say they came up to you and they're on prednisolone and they start telling you the symptoms that they're in adrenal crisis. You need to know that, because you would be expected to know where to refer them and things. So I can't say to you, you need to know this, this, and this, but you need to be able to know what you're going to need to know on day one. Is that half answered the question? Because I can't say to you, this won't come up, because it might, you know what I mean? Like it could be anything in the BNF, couldn't it? So obviously they've given you the framework. You know what percentage of questions are going to be like in terms of high weighted, medium weighted. You know you're going to get a question on insulin. You know you're going to get a question on sodium valproate. You know you're going to get questions on the high risk drugs. No, you're not putting on too much pressure. It's fine. Like I'm fine to talk about exam prep. It's hard to tell you what depth you need to know, because you're better to know too much than too little. Like I don't want to say to you, oh yeah, you don't need to know that, because that's not true. Like you need to know the BNF, but you've also got to think, what would they expect a day one pharmacist need to know, if that makes sense? Because I remember when I was revising, people would ask questions about, oh, what do you think about this? And I'd think, well, I don't think we need to know that. So obviously take these sessions, use them as a basis, use your BNF, use your notes, use your treatment summaries, and go from there, really. Has anyone got any other questions about exam prep or respiratory or GI or anything else that they might be able to help with? We've got 6 minutes. I'll just check the slide. No. Okay. So you get a green tick for today's session, which is GI and respiratory. And the next one is cardiology, which I believe, Atif, is next Sunday, isn't it? Is that right?
I believe so, yes. So,
yeah.
Just make sure that you're keeping up to date with these sessions. If you are ever needing to go back to them, all the recordings are available on our website. And the key thing is, it's January. It's time to maybe set some targets and goals. Like Katie was saying before, not long left, about just over 5 months. There are going to be some free sessions coming up in terms of time management, how to avoid procrastination, etc. So do make sure you keep a lookout on that WhatsApp group. I think we're going to release some bookings today for a drop-in session with me in a few weeks' time, just so that you can start planning ahead. But that's all, Katie. Yes, and back over to yourself.
Well, yeah. So as we've said, just pace yourselves. Keep on top of it. You've attended these webinars, which is a brilliant start. So remember, we're on Instagram, Facebook, Twitter. As I said at the beginning, I found social media really helpful for revision and kind of using different, we do the kind of stories with the polls on the questions, and they're brilliant. Like I do them now because I think, well, this is really good revision and like up to keeping myself up to date. So that's sort of really helpful. And obviously we're on Facebook and Twitter as well. And as we've said, the WhatsApp group. So that sounds like that's where the free sessions are going to be released. So make sure you join on there, and hopefully you've enjoyed today's session. Thank you all for attending. And I will see you on the endocrine session, because that's the next one I'm delivering. Have a nice afternoon, everyone.